Hello and welcome to the Parkinson's Foundation Wellness Wednesdays webinar. The Parkinson's Foundation is a nonprofit focused on bettering the lives of those living with Parkinson's through improving care and advancing research. Importantly, everything we do is in close concert with our community to ensure that our actions are aligned with the needs and the priorities of those living with and impacted by Parkinson's disease. Parkinsonism is a term used to describe a collection of movement symptoms associated with several conditions, including Parkinson's disease. Today, we'll learn more about the types of Parkinsonisms and how they are diagnosed and treated. But before we begin, would like to acknowledge the Light of Day Foundation, whose generosity has made this programming possible. Thank you, Light of Day Foundation. The Parkinson's Foundation provides weekly education and wellness programs virtually through our PD Health at Home series, which includes Mindfulness Mondays, Wellness Wednesdays, Fitness Fridays, our expert briefings, and our Spanish language programming, Y Salud en Casa. Join us for next week's webinar on exploring financial and estate planning. Financial and estate planning can seem overwhelming, and many just don't understand what it is and why it's important. Understand during this webinar what estate planning is, what's involved, and how to begin the process of protecting your assets to ensure you and your loved ones are cared for. Don't leave your future to chance and gain the knowledge to make informed decision by joining us on next week's Wellness Wednesday webinar. You can find out more and register for our PD Health at Home programs at parkinson.org/pdhealth. And joining us today, I'd like to formally welcome our presenter, Dr. Jerome Lisk. Dr. Lisk is Director of Movement Disorders at MD Neurology in Denton and Flower Mound, Texas. He has been a principal site investigator in several national clinical trials in Parkinson's disease. Dr. Lisk is an alumni of University of Michigan in Ann Arbor, where he did research on immunotoxin therapy. He received a medical degree at the Medical College of Virginia and interned at the University of California, Los Angeles. He completed neurology residency and received a movement disorders fellowship at the University of Texas at Houston. Dr. Lisk has been a consistent collaborator and contributor to the Parkinson's Foundation, and we're so grateful to have him here today. Dr. Lisk, thank you for being here.
Thank you for having me. So I'm going to go ahead and share my screen, right? Thank you everyone for attending, and this is a lecture on, this is a talk with for the Parkinson Foundation on understanding Parkinsonism. So learning objectives is to learn what is Parkinsonism and other descriptive terms, because they can be confusing. Also to learn about different types of Parkinson disorders, including Parkinson's disease, atypical Parkinsonism, and secondary Parkinsonism. Discuss the similarities and differences in motor and non-motor symptoms of each one, and also understand how each is diagnosed and treated. So here are my disclosures here. So the vocabulary is something that people with Parkinson's and the people in general get confused all the time, because it's changed since the Parkinson's was first described. So first, paralysis agitans is one of the first descriptions of Parkinson's when it was discovered, but now we call it Parkinson disease. The name was changed, and many people just say Parkinson's. I have Parkinson's. Many times people say I have Parkinson's, they're referring to all types of Parkinson's. So doctors will call it idiopathic. We like to call it typical, also typical Parkinson's, or we could call it primary Parkinson's. Idiopathic is mainly used by doctors. Parkinson disorder is synonymous with Parkinson's syndrome, which is the same as Parkinsonism or Parkinsonian. Usually when people say Parkinsonian, they mean Parkinsonian features, which are the symptoms of Parkinson, which are the symptoms of Parkinsonism. Atypical Parkinsonism is like saying Parkinson's plus. Then we have multiple system atrophy that initially was called striatonigral It's not called that anymore. They moved on to Shy-Drager syndrome, which is not called anymore. It's usually called multiple system atrophy. And then we have Lewy body dementia, which Robin Williams had, the famous actor. And we have dementia with Lewy bodies, which is the same thing, and also diffuse Lewy body disease. So what is Parkinsonism? Parkinsonisms are symptoms of different Parkinson disorders. So all these disorders will have bradykinesia, which is slowness of movement. This is the main feature, and it occurs insidiously and usually unnoticed by people. Usually it's a unilateral tremor that people notice first. Now, the tremor is usually in one arm. You have decreased arm swing along with this, usually. Mainly it's slow at rest, but it could be postural, which holding objects when you're eating, drinking, or it could be an action tremor when you're reaching for something. But you don't have to have all three. Many people don't have a tremor at all. Rigidity of muscles, people feel stiffness, and this could be perceived as weakness. And then when I do a neurological exam, or we do neurological exams on people, we see they have good strength, but they have this rigidity that makes them feel weak. Postural instability, difficulty with balance, and what they call anticipatory reflexes, which means when you start to lose your balance to regain your balance, that could be an issue too. And sometimes you could have falls. Also, then there's the poker face, which we call as doctors mask faces, but it's just like a poker face. And you could also have stoop posture and progressively smaller handwriting, which the progressively smaller handwriting can be one of the very first signs, even before the slowness of movement. People could then have short steps with a narrow base gait, progressing the shuffling, which is significantly smaller steps, like little baby steps. But some people have no shuffling at all in the very beginning. Or you could have freezing of gait, which means your foot are sticking to the floor and your body's going forward, but your feet are kind of still sticking and not moving at times. So we'll start off with typical or idiopathic Parkinson disease. People always ask me, is it mainly genetic? It's 85% sporadic and 15% genetic. However, when I was in medical school, say in the 94, 98, it was 5% genetic. Then when I was in residency, it was 10% genetic. So I think this may continue to increase. It's a 2-to-1 male to female ratio. Males get Parkinson's more than females. And the average age is 60 years of age, and young onset Parkinson's is before the age of 50. So United States, we say you need 2 out of 3, which the slowness of movement, remember the bradykinesia, that usually happens first, unnoticeable, but 2 out of 3, slowness of movement, unilateral tremor, or muscle stiffness. And you just need 2 out of 3. You do not need tremor. And you could have plus or minus postural instability, present or not present. At least 30% improvement to the physical symptoms, which are tremor, slowness of movement, or stiffness, to a medicine ingredient called levodopa. You've probably heard of Cinemed or Rotari. There's an ingredient called levodopa in there. And the generic for Cinemed is carbidopa levodopa. So you could have a subjective or objective improvement, but it needs to be an objective improvement. And it's usually the immediate release, and that's a gold standard. So the main non-motor symptoms are REM sleep behavior disorder, which is acting out your dreams, doing purposeful movements in your sleep where you're fighting or reaching for something, but the patient is completely asleep and unaware of what they're doing. They may choke or hit their bed partner, and this could happen an average of 12 years before the first physical signs. I've known patients to say it happens 20 or 30 years before, and it can happen one time and then never happen again. So it can even happen after the diagnosis. But when you have that, 60 to 80% of patients can have either Parkinson's disease, multiple system atrophy, or Lewy body dementia. So one of those three will follow this about 60 to 80% of the time. Decrease sense of smell can also happen, or complete loss of smell. This could happen before the physical signs. Some patients say they have that lifelong, along with constipation, can happen before the physical signs. And something we'll get into in a second called DAT scan. That's a nuclear medicine scan they do in radiology, and the radiologist does it and doesn't look at the brain. It just looks at areas of the brain that deal with dopamine, and we'll get to that in a second. That's usually positive in all these disorders that are typical and atypical. So just briefly, in the UK, we need to have people in the UK that look at these lectures. This is the UK criteria. Once again, you see the slowness of movement, the muscle rigidity, the resting tremor, and the postural instability, but they have all this exclusion criteria. And most of this exclusion criteria deals with secondary and atypical Parkinson features. Okay. So they're a little bit more, they have a bit more extensive criteria than we do. So we're getting away from stages of Parkinson's disease. Most common question, what stage am I in? And when you look at 1, 2, 3, 4, 5, that's what we call the Owen-Yar stage. That's mainly used for research. Doctors, will tell patients, you're usually mild, moderate, severe. That's how we talk to people. And those are really the stages we talk about. And we're getting away from talking about research stages to people as far as clinical stages. So you have typical and atypical Parkinson's disease, the similarities and the differences here. Like I said, there's Parkinson's disease, which is the typical idiopathic. Secondary, you can have drug induced from medications. We'll get into that. Normal pressure hydrocephalus, where you have fluid on the brain. Toxins or chemicals, pesticides, organic solvents, Agent Orange. Then there could be psychogenic Parkinson's or conversion disorder from stress or post-traumatic stress or depression. There could also be vascular, where you have multiple strokes and sometimes whole brain radiation. After certain cancers, you have to give people whole brain radiation if they have the cancer goes to the brain, and that could kind of induce a Parkinson's-like state. So those are secondary. Then you have the atypical, which are multiple system atrophy, which are two subtypes there, Lewy body dementia, progressive supranuclear palsy, and frontotemporal dementia with Parkinsonism. Now, there are more of these secondary and atypicals, but these are the ones we kind of deal with the most. These are the more popular ones, but there is a more extensive list. So typical and atypical similarities are slowness of movement, muscle rigidity, postural instability, difficulty with maintaining balance or posture, which if it doesn't happen early, it eventually happens. Non-motor symptoms, these are non-physical symptoms, which these non-motor symptoms could be more disabling than the motor symptoms. MRI of the brain is usually normal or non-specific signs. You cannot diagnose any of these atypical or typical Parkinson's on an MRI of the brain. Now, the secondaries, you could see that on an MRI of the brain. The DAT scan is always abnormal in typical and atypical Parkinson disorders. So sometimes the radiologist will put on there consistent with Parkinson's disease on your report. If you see that, that radiologist is probably not putting it on there correctly, and it needs to say Parkinson disorders, so that you have a Parkinson disorder, which could be typical or atypical. Differences, presence or degree of tremor. Some of the atypicals, patients rarely have tremor in some of the atypicals. Onset of non-motor symptoms, they happen early in the atypicals. Response to medications for levodopa. Patients don't respond to the medications that have atypical Parkinson's, or they have a minimal response. How fast the symptoms progress, they progress faster with atypical. And the neurological exam could be a little different also. So here we're seeing with the brain, you can see that in the early stages 1 and 2, over here on the left, you can see that it starts off kind of, a little bit in the brain stem there. That's the bottom part of the brain. And then it slowly, in stage 3 and 4, spreads to the brain and then this keeps on spreading in these later stages. So in stage 1 and 2, you really don't have any symptoms. Okay. But that's when all those other non-motor symptoms, REM sleep behavior disorder, decrease of smell, constipation happens when there aren't any physical symptoms in those early stages. So really, we're seeing Parkinson's disease in the middle of the disease when you have physical symptoms. So here is a DAT scan. So if you see at the top, PD means Parkinson's disease, PSP means progressive supranuclear palsy, MSA means multiple system atrophy. Those little circles, that is an abnormal scan, and they all look the same, typical and atypical. You see at the bottom, the comma, where you have the tail. The tail was lost on the top row, but the tail is present on the bottom row. It looks like a little comma. That's a normal scan. That's drug-induced, normal pressure hydrocephalus, essential tremor. It's normal in Alzheimer's and other type of non-Parkinson disorders. So just an example how medications can make patients with patient stat scans look abnormal. Here's a patient that had Namenda and had Zoloft, and the DAT scan was abnormal at first. We took the patient off the medications. The DAT scan is normal. This patient does not have a Parkinson disorder. So early, if we're looking at early, well, red flags, when is it not Parkinson disease? Abnormal eye movements, stroke-like symptoms, exaggerated muscle jerks, severe, we call it dysarthria, which is difficulty speaking with stridor or hoarseness. Early frequent falls, multiple falls early, are people that have cervical dystonia where their head is built is down like this. This is called anterior collis because it's going anterior, and they cannot raise their head. That's frequent with MSA, multiple system atrophy. Neurogenic orthostatic hypotension, loss of regulation of your blood pressure. You stand up, and after 3 minutes or after an hour, your blood pressure drops more than 20 points. That is the autonomic nervous system. That early indicates atypical. Dementia or psychosis. People with Parkinson's don't get dementia in the first 5 years or hallucinations. And this false sense of presence, seeing a shadow in your peripheral vision and you look and it's gone. That's a visual hallucination. Loss of postural reflexes, unable to stand straight without assistance. You just kind of fall back. That could be a sign where you can't maintain a standing posture. Difficulty swallowing, and also loss of bladder control. That could be related as well. So confusion of symptoms, you could have, it could be mistaken for, that could be mistaken for visual hallucinations. We see all the time. And this is seeing images when you're dreaming and waking up from sleep, because you're seeing your dreams, which are hypnopompic. And then also when you're falling asleep, you could have hypnagogic because you're starting to dream, but you're just not yet asleep yet. You're seeing your dreams. And when people have vivid dreams, they can report them as visual hallucinations. And of course, if you take naps during the daytime, this could happen. Restless legs, restlessness when sleep, periodic limb movements. Restless legs are when you're having a sensation in your legs that delay the onset of sleep. Or with the prolonged sitting. People will mistake this for acting out your dreams, okay? And then the periodic limb movements are when your legs are twitching at night, but it doesn't bother you, it just bothers the person sleeping next to you, and it could wake you up from time to time. So atypical Parkinsonism. So we have drug-induced Parkinsonism. The number one cause in the world is a drug called Reglan. It's used for nausea, okay? And sometimes it's used after surgery to make sure your bowels keep on moving. So you have to be careful about this in the hospital, especially if you have Parkinson's disease, because it can make it worse. And the Parkinson Foundation has a list of medications you should avoid or be cautious with Parkinson's disease. Antipsychotics, Haldol, as an example. Second generation atypical antipsychotics like risperidol, Abilify. The most common one I see is Abilify, probably because it's prescribed more frequently than the rest. Antipsychotics like Clozaril, Seroquel, Nuplacid don't really block dopamine and do not cause drug-induced Parkinsonism. Depakote can cause progressive cognitive impairment and Parkinsonism usually about 7 to 12 years after being on Depakote. I've seen a case of IV amiodarone cause acute moderate Parkinsonism overnight. And these other medications called VMAT2 inhibitors, see these commercials on TV for tardive dyskinesia called Austedo, Xenazine, Ingrezza. These medications usually cause it at a high dose. So usually not low doses, or if you're titrating up rapidly, you could see that. Most of all these medications are fully reversible, anywhere from 2 to 12 months. And the neurological exam cannot distinguish between typical, atypical Parkinson's in this case. Lewy body dementia, first formal discovery, diagnosis, 1996. And they called it Parkinson's disease dementia at first. Females have it more than males. Progressive cognitive decline leading to early dementia in 1 to 2 years. This is commonly mistaken for Alzheimer's because then about within 1 to 3 years after you start having the cognitive decline and memory loss, you don't have any Parkinson's symptoms. Then all of a sudden, couple of years later, you start to have these Parkinson's symptoms, or they can happen along with it as well. And that's the rigidity, tremor, and slowness of movement. And also, people with Lewy body have a fluctuating alertness during the day. They can go up and down during the day, where they're sharp 1 minute and they're confused the next minute. Their attention and alertness. And they could also have dysfunction of that automatic or autonomic nervous system. I like to tell patients it's the automatic nervous system. That's where the blood vessels squeeze to get your blood pressure up with normally. In neurogenic orthostatic hypotension, those blood vessels don't squeeze. So when you stand up, gravity ensues and the blood pressure drops more than 20 points. Hallucinations occur pretty early within the first 1 to 3 years, and they can be formed or unformed, like I mentioned, false sense of presence before, where you see a shadow and you look and it's gone. It's not in your direct vision. Multiple system atrophy, you have MSAC that was described in 1900, and MSAP described in 1960. And so there's two types, the Parkinson type MSA, multiple system atrophy, and the cerebellar type. Median age of onset is 56 years, plus or minus 9 years. And there's really not a big difference in male and female incidence here. Disease progression is faster than Parkinson's disease in the first 5 years. Median survival, 6 to 9 years, plus or minus 5 years. Usually measured from diagnosis of symptoms, not symptom onset. I always tell people you want to say, even with Parkinson's disease or any of these, you got it when you first had symptoms, not when you're diagnosed. Okay? That's the year you want to use. And REM sleep behavior disorder, of course, could happen in this one. So here, just briefly, here are some of the differences between these two types of MSAs. The MSAP, both of these have rapid progression. You have frequent rigidity, bradykinesia, rare tremor. Seldom do you have tremor in MSA. You can have the cervical dystonia I mentioned with the anterior colus. The neck is pushed forward and it's difficulty to raise it. That can affect swallowing. Urinary incontinence, the neurogenic orthostatic hypotension, where you stand up and the blood pressure drops. You can get dizzy and pass out. You can have your knees could buckle and you cause falls. And with both of these, the response is to levodopa is less than 30%. So all the atypicals, you have a less than a 30% response to levodopa. If you have more than a 30% response to levodopa, then that is more indicative of Parkinson's disease. And within 5 years, you have loss of postural reflexes. MSAC, you have more early falls and coordination, eye movement abnormalities, and progressive dementia. So differences in disease progression. This is a picture to show you. You see the onset on the left, we have Parkinson's disease progression, and on the right, you can see the atypical is faster. Okay, so here within 3 to 5 years, the patient's already using a walker and a wheelchair. And of course, this is not everyone. Everyone's different. So when we're talking about these diseases in this lecture, remember, everyone's different. So some people may be able to last a little bit longer. Maybe they get to a wheelchair in 8 to 10 years, okay? But you can see the differences of progression here. So progressive supranuclear palsy, recognized in 1955, then published in 1964 by Steele, Richardson, and Olowski, which was called Steele-Richardson-Olowski syndrome. The average age of onset, 63.5 years, somewhere anywhere from 50 to 77 years of age. People will have slow vertical up or down eye movements. It could be paralysis where they cannot look up and they cannot look down with their head still, or it's slow movement up and down of the eyes. That could be a sign as well. Repeated unprovoked falls within 3 years, frequent falls, falling multiple times a week or a day. Symptoms, the The symptoms are symmetric. The slowness and the rigidity is symmetric, not just one side, like idiopathic Parkinson disease. And people will get this progressive non-fluent speech. They have really difficulty with speech and expressing speech, and it can be really hoarse, and they could really have to strain, difficulty swallowing, and progressive cognitive decline leading to dementia. And they could get tremor and psychosis and autonomic dysfunction are uncommon in progressive supranuclear palsy. So frequent milestones, frequent falls. We have here wheelchair, 6.4 years, plus or minus 2.7, severe swallowing difficulties, and the disease duration is anywhere from 8 to 4.1 year, about 4 years. And remember, it's from the onset of symptoms, not from diagnosis. Cortical basal ganglionic degeneration, 1967, 3 cases were reported. People have limb rigidity, more females than males. Average symptom onset is 63 years of age, plus or minus about 7.5 years. And asymmetric symptoms. Symptoms are worse on one side than the other. You could have sensory loss, numbness, which we call sensory loss, difficulty performing learned movements like brushing my teeth or combing and brushing my hair, which people forget how to do things they already know how to do. Alien hand syndrome is where the hand will move, will grip something. You're gripping something like a chair, you're gripping something, or you're gripping the couch, and then they look and they can release it. And they don't even know they're doing it. Focal muscle jerking, doctors call that myoclonus, where when you're falling asleep and you jerk and it stops, that's focal muscle jerking. And then you have contraction of postural muscles, so which we call a dystonia, where say your hand is like this and you cannot move it because it's an abnormal muscle contraction that holds a posture, just like the cervical dystonia. Abnormal muscle contraction that holds a posture. That's called dystonia. And it can happen anywhere in the body, the hands or the feet, the neck. Then we have frontotemporal dementia with Parkinsonism, FTD, PD17. There's genetics with these, a couple genes, described in 1996. Average age of onset is 50 years of age. Disease duration 5 to 20 years. Early change in personality. People can have poor judgment. They're impulsive. They have mood swings. They can have OCD is common also. Dementia usually occurs first and followed by Parkinsonism in 3 years. Bradykinesia, slowness of movement, rigidity, muscle stiffness, postural instability, being able to stand up without falling over, and rare tremor can occur. Language difficulty with expression of speech, word naming, the meaning of words, visual hallucinations, delusions. And you could do what they call a PET CAT scan of the brain. When it's positive, it's positive. But when it's negative, it doesn't mean you don't have it. So it could miss a good part of it. We do not use the medications we use in Alzheimer's for dementia, which are Aricept, Exelon, Razidine, Namenda. These are medications used in Alzheimer's disease. You can't use these in frontotemporal dementia because it will make them worse. And so if you're misdiagnosed with Alzheimer's disease and the patient uses these, and I'm not talking about the side effects like diarrhea or upset stomach or abdominal pain, but if it makes the dementia worse and the behavior worse, that's what we're talking about. So antidepressants are frequently used in frontotemporal dementia with Parkinsonism. So secondary Parkinsonism, normal pressure hydrocephalus, first described in 1964. You have enlargement of the ventricular system. The ventricles are spaces in the brain, which I'll show you later, where the spinal fluid is, okay? And so the spinal fluid is altered by flow or reabsorption, and it gets enlarged, and those ventricles get big, and they call that hydrocephalus. And it's frequently misdiagnosed as Parkinson's disease, okay? So the classic triad is you have symptoms of Parkinsonism, the slowness of movement, you have shuffling, rigidity, and you have urinary incontinence. It can start off as urinary frequency, then progress to urgency, then incontinence. And you have progressive cognitive impairment where it slowly progresses to dementia. That's a classic triad, okay? the diagnosis and treatment of NPH, normal pressure hydrocephalus, is you don't have a response to levodopa, but I see patients have a subjective response. That's why we do a neuro exam before we give the levodopa, then we give 200 milligrams of, say, Sinemet, carbidopa levodopa, and then we check the patient 1 hour afterwards. And if they have a more than a 30% response or more, then we know it's more likely Parkinson's disease. If they don't, we say it's a suboptimal response or no response. MRI of the brain and CAT scans, we'll see enlargement of these fluid spaces in the brain. This can be missed by many physicians, radiologists, or other non-movement disorder neurologists. And it could be difficult because of, as we get older, our brains shrink, and that's called atrophy, the shrinkage. And you can have only mild enlargement that can look normal on a brain scan. So when that happens, we'll send you to a neurosurgeon and have a lumbar drain done, or we'll send you to a radiologist at the hospital and they'll drain off spinal fluid on a spinal tap. And they'll look at your walking before and after the lumbar drain or spinal tap and see how much improvement you have. And if it's significant, then you go to the neurosurgeon and they'll put in a shunt in the brain. So to drain that fluid from the brain, they tunnel that shunt down to the stomach and it goes into the stomach. It gets reabsorbed by the stomach naturally. And then there's another scan called a nuclear sternogram that can be normal. It's not reliable test. So here we have a normal brain on the right, and then we have the NPH brain. Oh, sorry, we have a normal brain on the top, and we have the NPH brain on the bottom. Okay? So you see how the top, the ventricles are a certain size. At the bottom, the ventricles are larger. That's those fluid spaces, those ventricles. Here is a normal pressure hydrocephalus that I did when I was in Tyler, Texas, and it caused the DAT scan to be abnormal in a patient that already was diagnosed with NPH with a positive lumbar puncture and responded positively to the lumbar puncture, large volume tap. This is a right frontal meningioma. That's a brain tumor with mild surrounding swelling here on the right. That's a picture of the brain when they're cutting it this way. And then this bottom picture is when they're cutting the brain this way here, and you see the large tumor. It could make this DAT scan look abnormal. This is from the Neurology journal, all these images. Then you have a midbrain brain tumor meningioma, and you have at the bottom there's a butterfly astrocytoma. And here we have a partially thrombosed middle cerebral artery giant aneurysm compressing the left part of the middle part of the brain called basal ganglia. And you can see that there. You see the white area here on the right side of the brain there. And that's the aneurysm. See the white arrow pointing to the aneurysm. So treatment. These are medications that are used to treat Parkinson's disease. Now, these medications are usually used for movement, these levodopa-containing medications, Sinemet, ER, IR, Stalevo, Retari. Retari is the only extended-release Sinemet. When you say Sinemet ER or CR, that's more of a delayed-release Sinemet. It's not extended-release, and that can be confusing for patients. So the Retari is the only one that's truly extended release. The ER is delayed release. It takes about 1 or 2 hours. It's delayed. Ambrosia, that's inhaled levodopa, dopamine agonist. That's Mirapex, Requip, Nupro, Apokyn, and Kenobi. This Kenobi is where you sublingual, you put under the tongue, apomorphine. That was taken off the market in December of last year. Hopefully it comes back. And you have these MAOB inhibitors. This MAOB is an enzyme that breaks down dopamine in the brain. So these medications will kind of slow that breakdown there. Also, I like to mention you could get the carbidopa on its own, and the brand name for that is called Lidosin. There's another medication called opicapone. that goes on the other slide as well. That, well, down here at the bottom called Ongentys. There's Comtan. That's another, the COMT inhibitor is another medication that will inhibit the enzyme that slows down the breakdown of dopamine. And so Comtan and Ongentys will allow more dopamine to be present. You have antipsychotic, Nuplacid, that's for psychosis. You have this adenosine receptor antagonist, Neurionts or estradifylline, that is used for helping control motor symptoms. And then at the top, amantadine and Gocovri, those are used for mainly dyskinesias, but they could also help with symptoms of Parkinson's disease. Northera, that's also called droxidopa. That works for the NOH, the neurogenic orthostatic hypotension, which is autonomic nervous system dysfunction, where your blood pressure drops 20 points when you stand up. Now, I have a lecture on this that we could talk an hour just on treatment. So this is just an overview. So medications used in typical and atypical Parkinson disorders, when we're controlling daytime drooling, that indicates swallowing dysfunction where you're not swallowing enough. And so then, of course, it comes out the other way. Your doctor would do a modified barium swallow study. It's a swallowing study if your symptoms are mild and moderate, but that's the first indication of swallowing dysfunction. In these Parkinson disorders, people mainly pass away from or get hospitalized because of pneumonia. That's what usually will cause death. And so it's important to recognize the moderate swallowing dysfunction early and get someone to a speech therapist. But glycopyrrolbanol is a medication. That's an oral medication. You could use atropine drops under the tongue, or you could use botulinum toxins. And remember, Botox is a brand name. There's 4 of them here: Myobloc, Xeomin, Dysport, and Botox. And those go in the salivary glands here, in the parotid gland here for drooling. Then, of course, neurogenic orthostatic hypotension. There's a lot of natural things you could do for this. Hydrate, drink plenty of water, add more salt to your food. I tell people Himalayan salt has more minerals. It's healthier for you. Compression socks, abdominal binders, something to go across your abdomen, and Velcro where it's tight. Spanx is a form of that if you get up to your abdomen, or you could wear Spanx up to your knees. Then there's medications. Here, fluticasone, droxidopa, and midodrine. Remember, these 3 medications can make the blood pressure go high when you're laying flat. They could cause more elevated blood pressure when you're laying flat. And this disorder already does that anyway. Okay, so midodrine does it the worst, then fluticasone and droxidopa does it the least. Those are all generic, by the way. Dementia, we use medications to slow the progression. They typically don't improve memory in about 90% of people, but then 10% of people will say, I had improvement to one of these 3 medications. And as I mentioned, we're not using this in frontotemporal dementia, which are Exelon. There's an oral medication that has a high incidence of diarrhea. The patch, very low incidence of diarrhea. That's a daily patch. Aricept, there's a weekly patch for that, and there's an oral medication, and there's a 23 milligram and 10 milligram and 5 milligram tablet for Aricept. Razidine, and then there's an add-on to one of those 3 called Namenda. Then we have visual hallucinations, delusions, or behavioral problems, and we usually treat that with Seroquel, Nuplacid, which is FDA approved, or Clozaril, which is rarely used, but you need weekly blood draws because of the 1% chance of lowering the right blood cells way too low to dangerous levels. So mainly the first 2 we use, Seroquel and Nuplacid. And Nuplacid's only approved in Parkinson disease psychosis. So the other atypical Parkinson's disorders, we're using mainly Seroquel. So non-medication therapies for Parkinson disorders: surgical treatment, deep brain stimulation, or MRI-focused ultrasound. These are not for atypical and secondary Parkinson disorders, only typical Parkinson disease. And there's a whole qualification for this. We get to have another hour lecture on this. You don't get this in people that have dementia. Also, typical and atypical Parkinson disease. So for the deep brain stimulation, your doctor may send you to a neuropsychologist first to make sure there's no signs of dementia. typical and atypical Parkinson disease, physical therapy, occupational therapy. There's a Lee Silverman voice program. So we have the Lee Silverman LSVT big, and we have LSVT loud. Okay. The big is large amplitude exercises, physical therapists. LSVT loud is for basically speech therapists. Strenuous exercise, 30 minutes to an hour a day. And that's not, the gardening or just working out, doing, chores around the house. Exercises, Tai Chi, you guys have heard of that. One thing you may not have heard of is Qigong, which is like Tai Chi. Yoga improves flexibility, improves rigidity, reduces falling. Rock steady boxing, cardiovascular coordination, helps with leg agility. And that's a nationwide program, Rock Steady Boxing, just like Dance for PD, which improves leg agility and reduces falls. I've treated semi-professional dancers, models, and also other soccer players that have very great leg agility and they almost never fall. So dancing is a great one for reduced falling. Cycling reduces freezing of gait. Light weights improve strength. Art therapy encourages both large and small amplitude movements, helps with stress relief, emotional expression. There's medical massage, and of course, there's acupuncture. So this is a very busy slide. I just wanted to show this. This is something I put together as a poster. And as you see, my attempt was to put typical, atypical, and secondary Parkinson disorders. This is more for doctors, but you see how abnormal DAT scan for typical, atypical. Usually it's normal for secondary, except for normal pressure hydrocephalus or brain tumors. And you see the common non-motor and motor symptoms at the top. Well, I'd like to thank you all for looking at this lecture, and I hope to see you at another presentation.
Thank you so much, Dr. Lisk, for your time and for sharing your knowledge today. I really appreciate the way that you continue to show up in support of our community around the nation and across the globe. Really appreciate you.
Thank you. Thanks for having me.
Of course. Please do not hesitate to reach out to us if you have a question that we could not answer today. We have a comprehensive website and many more resources that could address everything related to Parkinson's disease at our website, parkinson.org. You can also call our helpline at 1-800-4-PD-INFO or email us at helpline@parkinson.org. Thank you for joining us today, and I will see you again somewhere in Zoom land. Be well.